Great. So thanks very much, speakers, friends. Hope you enjoyed that. Time for some questions from the audience, and the first batch are probably for Jesus, and it's about the heritability of cholangiocarcinoma. To what extent are these cancers inherited? There's a couple of questions about that. There's a question about germline mutations that are found. So that's a similar type of question. And then slightly unrelated, but sort of related, is somebody's asking about hemochromatosis and the impact of hemochromatosis on the incidence of cholangiocarcinoma. Maybe I'll ask Juan. I'll ask Juan the question about hemochromatosis. You just concentrate on the first two, please, sir.
Thank you, John, and thank you for the questions. Unfortunately, we don't have too much information on mutational profiling in the patients. This is something that we are looking for prospectively to get more information on that, now that the molecular profiling is becoming a little bit more general. So this is something that hopefully we can investigate in deep in the future. And similarly, regarding the heritability, we didn't take a look on potential association on family records on cholangiocarcinoma, but this is something that maybe we can address in the future. But for the moment, we didn't take a look yet. So this is the first large analysis of the database, and definitely there are a number of studies ongoing now.
Fantastic. Juan, the hemochromatosis, is that something to worry about? Is that a cause?
Yeah, so I think the mechanism here is more around cirrhosis. So cirrhosis is repeated scarring in the liver due to damage which happens over a prolonged period of time, usually 20, 30 years. In the past, with cirrhosis, we've often thought of liver cancer, but in fact, it's the hepatocellular carcinoma, the cancer that arises from the liver cells rather than the bile ducts. We do now know that cirrhosis is also a predisposing risk factor for cholangiocarcinoma, and hemochromatosis, which is excessive iron deposition, can cause cirrhosis. So through that route, there would be a connection. So in families who do have hemochromatosis, who are therefore at risk of cirrhosis, there will be a connection there.
Okay, great. Thanks very much. A number of questions about stents, Renuka. There's a question about somebody's stent having disappeared. What's happened to the stent, and is it something to worry about?
It does happen sometimes that the stent migrates, and so it's lodged somewhere in the bowel. And if that happens, nothing to panic, nothing to worry. If the jaundice has gone away and the treatment that the person's getting is working, it is possible that you don't need a stent anymore. And I think the team that put it in would certainly wait and see when you have new symptoms and decide whether you need another one.
Okay, thank you. Another sort of stentish type question here about pancreatitis. Somebody got bad pancreatitis. So what is that common? Can it be prevented? What can we do about it, please?
So I'm happy to take that one if you want. Pancreatitis is an accepted complication of putting a stent in. Thankfully, it doesn't happen very frequently. Depending on what series you look at, the likelihood of developing pancreatitis is in the region of around 3 to 10%, mostly around 3%. Remember that the risk of pancreatitis, which can be severe, is outweighed by the risk of not dealing with the blocked bile duct, which, as I said in my presentation, becomes increasingly life-threatening if it's not dealt with. So it is an accepted complication, not one that we welcome, but often one that can be managed.
Okay, brilliant. There's a question about the disposition of the different subtypes, and that's perhaps a question for both Renuka and Jesus, who both presented some data on that. intrahepatics versus the others. It appears to be from what you presented. Is that real? You know, over 60% of patients with cholangiocarcinoma are intrahepatics. That appears to be what you're both telling us. You can take turns in answering. So Jesus first, please.
Yeah, thank you for the question. Yeah, this is a bias.
3311. I mean, are those really reliable data?
Yeah, this is a bias because a significant proportion of the cases were included by hepatologists, so that's why they are intrahepatic. So this is not an epidemiological study, so we need to take this in consideration. But what we see is that if we compare all the three subtypes, there are interestingly significant differences in many aspects, no? In risk factors, in presentation, even in the management and outcome, no? In certain cases, no? In intrahepatic, particularly after surgery, they show a different outcome compared to perihilar and distal, and also in patients under breast supportive care. So this is something that we need to understand why this is occurring and try to dissect a little bit the answers.
Okay, thank you. So Renuka, is that right? Is what he said correct?
I would agree. I think the sort of common theme here is it's what database are we looking at, you know, and who is inputting the data from where we're looking. And to the question, one of the that was raised, it was also about Europe and other parts of the world. And to Jesus's point, it's different in different parts of the world. And the data I presented was largely a US-based, claims. So it's really more speaking to who was encompassed in that claims grouping. And I don't have details of the regions of the US exactly, you know, so I can't speak to that much. But certainly I think knowing where the data came from is key. And the message in the work that we were looking at was more complications. So I think we focused less on exactly how many cases there were of each subtype.
Okay, brilliant. More questions coming through now. Jesus, please, any European data on outcomes after liver transplantation?
Well, that's a good question. We have a significant number of cases included. We cannot do a full analysis and comparative analysis yet, but we are looking forward to do that. In the cases of tumor resection, complete resection, we also included some cases of transplantation. So this is a reflection of both aspects, liver transplantation plus complete tumor resection. But the results provided by the Mayo Clinic, the retrospective data from 1993 to a couple of years ago, and also data from Toronto are very promising, no? In the case of liver transplantation, before it was contraindicated, but new data indicate that through certain criteria, it can be a good tool also, no? So hopefully we can compare specific data on liver transplantation in the registry. Yeah.
Terrific. Good. That's very interesting. So a couple of questions about essentially doing the work again, Renuka and Juan. So you've compiled this roadmap, and Renuka, you've given us the first trawl of this. Do what are you going to do? Are you going to see whether it's made any difference? What's the sort of longer term plan to see if these guidelines have made an impact? That's one question. And slightly related to that is around the use of the card. You turn up with your biliary card. How important is that? Should all our patients be carrying one? So perhaps the second time round question first, the reevaluation question first. Juan, and then Renuka comment on it with the other bit, please.
Thank you, John. I think it's absolutely right that we measure the impact of our intervention. We're not quite completed with the intervention yet, although we've done the guidelines. One of the things that Renuka was able to highlight is that you're 10 times more likely to present at a different hospital to the one that had fitted your original stents. That's significant. And the other is that you're much more likely to be started on antibiotics by a specialist other than oncology. So I think what's really important here is that we have that dissemination piece, which we haven't yet completed. Just the one thing to add, and it's very much a personal view, is that when patients are unwell with biliary obstruction and sepsis, you look really sick and feel really sick. And my worry is always that if you turn up in an emergency room, it's considered that you are so sick because of the cancer rather than so sick because of an infection that can be treated and you can get back on track again. And so I think it's really important that we get the message out that patients with this complication, particularly with infection, are actively managed because it is reversible and they may be doing very well on their treatment.
Okay, and just a tiny follow-up onto that question. So how are you going to do that? How are you going to, we're amongst friends here, but how are you going to get that information out to these emergency room doctors? What's the? I mean, they're not all going to be attending this conference. They're not all going to be looking at the CCF website.
Yeah. So I think there's two ways that we can do that. We can do this top down, so looking through societies and maybe disseminating it through the various individual society guidelines and doing an awareness that way. But I'll hand over to Renuka in a second, because I think there is great strength in patient power, and I think patients being able to raise this as an issue when they are presenting, making it more visible, making it more of a common situation, I think will also raise the awareness bottom up, as it were.
Excellent.
Yeah,
Renuka, please.
I couldn't say it better than Juan just summarized. I think with Stacy after this conference and talking to you, John, and other thought leaders, we'd like to see whether the same problem happens in pancreatic cancer patients as well. And so if there's a way to pair up with other organizations, it's the same emergency room that the patient is going to present. And if we get the education, get the word out, once the provider there knows that this is something that's happening and this is something I need to be aware of, the work is done, it will help. But we have to be ready with continuous trainees, new people coming, that this has to be an ongoing effort. So having guidelines is important, but also having patients educated so they can speak for themselves. And for that, to the patients who are listening and also the providers, we send patients with heart stents home with a little card that tells them you need blood thinners or antibiotics or whatever when you're having a procedure. But there was no such thing for stents, where we know patients present far more often with problems. And now just going to the website, entering your own name and what stent or tube you have, when approximately it was placed, and carrying it with you or downloading it and having it on your phone would help you when you're in an emergency room. So the provider who's seeing you can take a look at it and see this as a physician-to-physician communication. And it doesn't come across as you're telling the doctor what to do. They won't take very kindly to that usually. And so the card is a way for the foundation and these guidelines to become easily accessible and add some weight to just, hey, stop a moment, take a look at this and think about cholangitis, call the primary team, at least talk together, and maybe it's not, but at least make sure you've ruled it out.
Excellent. So I think that's a fantastic point on which to end. Renuka is telling us it's much easier to educate the patients and the public than it is the doctors. Great. I love it. I think that's a fantastic point. So look, thank you very much, speakers. Superb presentations, really interesting. Jesus, I want those slides. And we'll touch base, hopefully face to face in due course. Thank you, everybody. And we move on to the next part of the show. Cheerio then.
Thank you.